Welcome to the CodeCast podcast. Real-world insights for your daily medical coding and billing processes. And now, here's your host, Terry Fletcher.
Hello, everyone, and welcome to the CodeCast podcast today. My name is Terry Fletcher. Today, we are at the 150th episode of the CodeCast podcast. We're close to 200,000 downloads and listens. Thank you very much. And we really just are excited to be here on September 1st. So I'm almost at 3 years of the podcast. You know, I wanted to put it out there too. I was planning on maybe switching it to every 2 weeks instead of every week, but I've got some loyal listeners out there. We're getting about 1,000 to 2,000 downloads a week. But for any of you that are saying, you know what, to every 2 weeks is fine, direct message me, email me, text me, let me know so that I can see what everyone's doing. If you're just catching up on episodes or if you truly go to find it every week. So I'm just curious what you're all doing. But I appreciate it either way that you're listening. So today is a day to basically let you know what September is going to bring in the form of CMS and Medicare. And they are ramping up, again, not to just beat a dead horse, their audits, but also ramping up some collection activity that you may or may not be aware of. I alluded to some of it last week in my top 10, but as of today, September 1st, the APP is due for many practices. And so I wanted to talk to you about what APP actually is. And what we're talking about here are the advanced accelerated Medicare payments. Okay, so when we talk about that, Medicare basically said they're out now, and it's been 120 days for some. And we said when you got those APPs that we were going to ask for the money back. Now, the American Hospital Association is trying to get them to delay it, and they're like, no, we told you this was coming back. And a lot of practices and hospitals are saying, well, if you were going to take this, collect this loan now, and again, it was a loan, the only funding that was a loan, then they're saying, well, we're going to go under. And they're like, but we told you. I mean, this is like the biggest I told you so ever. And that's why I labeled this or titled this episode, Rent's Due. CMS says, you know what? We told you about this 4 months ago, and we gave you so much funding and other ways to take in money that was actually considered a grant or a forgivable loan. This isn't one of them. We accounted for this, and that's why we stopped it after 6 weeks of allowing it, where they said, we need to get this money back to be able to fund future payments. And that's what it is. So as of September 1st, they're now taking back that money. And so if you applied for that against my better judgment and against my advice, just know that as of today, you're going to start seeing offsets in your Medicare reimbursement checks. And that's another thing. They won't let you just pay it back, and they won't let you extend your time. They're going to offset your Medicare money. So you're going to see that in your checks. And if you don't have anything coming in within the first 2 weeks it's due, they will also append a 10.25% interest rate. And so it's almost like a loan shark thing. I'm just telling you, you fell into it, and this is what to expect. September 1st also brings something else, and this is going to be very big for many of you that have also been treating COVID patients. So what we've had happen, and I've taught this not only in my telehealth webinars, but also in just regular, Medicare updates, is that if you have a patient who either is testing for COVID or being treated for COVID-19, then you can apply a CS modifier and a certain particular diagnosis and get paid for that service at 100%. And that diagnosis, of course, was the U07.1. And if you got paid 100%, it means that you can't charge the patient their out-of-pocket. Well, here's the problem now. So Medicare basically said, based on some feedback they got and some preliminary reviews and going back and taking a look, Medicare said, well, we're going to do some post-oversight. So, and they found some major inconsistencies in the accuracy of some of the COVID-19 tests and the fact that, again, they've been paying that additional 20% to providers and facilities. And again, they call it treating patients with COVID or testing for COVID. So now they've enlisted a mandate as of September 1st today to continue to pay for the 20% that would have been traditionally been the patient's out of pocket. They now are going to require hospitals that they have a positive COVID-19 lab test in the patient's records to qualify for Medicare's 20% add-on payment. So it first came out that you only needed to have just a copy of a test. No, the new mandate, which you can find under SE 20015, and that is the new bulletin, which CMS seeks to address, okay, they said it's because of potential Medicare program integrity risks. And they said that until now, guidance has been said that it's the provider's documentation, not necessarily a positive test result, that was sufficient enough to receive that 20% higher Medicare reimbursement for inpatient COVID treatment, and also sometimes for outpatient, depending on the modifier. And CMS said they will continue to apply the 20% add-on payment for COVID-related claims after the final rule takes effect today, but that there will be post-payment audit reviews to enforce this requirement and sort of a post-oversight, if you will. And the extra 20% will be recouped if no positive test results are found. So it's interesting because when I read through the document that I just stated, it didn't say positive at the beginning. It just said a test result. And then they went on to say that there has to be a positive test result, and that's going to be the problem. Not only from an administrative burden on hospitals and many physician practices, but the fact that COVID-19 tests have become more widely available, and many hospital systems have treated thousands of patients who may have tested positive and at some point during the pandemic, but then had several repeated tests to get a negative result, or repeated tests if initially testing positive but were asymptomatic. So now CMS, in the later stages and hopefully heading towards post-pandemic era, to make sure that patients are not being labeled or diagnosed with COVID-19 when they did not test positive or were not treated for COVID, but a diagnosis or CS modifier was added to the claim to receive the 20% payment, they are now going through and retesting, or I should say now post-reviewing. So because they said that would be fraudulent. So the American Hospital Association, they're asking CMS to reconsider the new requirement. The lobbying group contended in a letter sent to CMS Administrator Seema Verma last Wednesday. They said that requiring test results would put a substantial administrative burden on hospitals, and provider documentation should continue to suffice. But you should have a test in the chart. They also, their argument also fell back on ICD-10 coding advice that the COVID-19 diagnosis code on clinical judgment alone, in line with what we've been told on the coding rules, and continues to be an important approach given that test accuracy may not be reliable. Retesting is unnecessarily erroneous, and some communities face persistent testing shortages, which right now that's not true. There's so many tests. I get emails or direct messages every day saying, does your team need this? And so this is where their argument is, but I think they just don't want the paperwork and having to prove it. The problem also CMS is going to find costly is that in addition to a provider's confirmation, hospitals have now been able to use state or local COVID test results, even if they weren't confirmed by the CDC, to get that 20% add-on payment. That's no longer going to fly. CMS now requires viral testing, meaning molecular or antigen testing, consistent with CDC guidelines. So the two ICD-10 CM codes used to identify COVID patients are U07.1 for discharges on or after April 1st, and before April 1st, it's B as in boy 97.29 for discharges on or after January 27th. So the AHA, the American Hospital Association, went on to argue that in some cases, hospitals may have to dedicate considerable amount of time and effort trying to get test results from third-party providers and manually entering them into their medical records. But the question is, will hospitals ultimately have to retest patients if they can't obtain their test results that they had prior to? Would those tests be covered? Because again, there's no medical necessity for retesting for administrative reasons. So this is a mess. And what my concern is from a compliance and honestly, and financial perspective, we will all of a sudden start to see a surge in positive tests because that's the only way as of September 1st to get the additional 20% payment from Medicare. So the rule did not just say test results, it said positive tests results. So CMS wants to make sure that the patients not having to pay their share of costs are true to COVID-19 patients, and that their efforts to ease financial burdens to COVID patients and to make up that difference to hospitals and providers was not done in vain, and that the Medicare program integrity is intact. So post-oversight is very hard to implement. So I would stay tuned to this development, because I just think this has opened up such a can of worms. It's awful. It's going to be a nightmare. So anyway, stay tuned to that. So those are two things happening as of today that Medicare is basically saying, you know what, rent's due. We gotcha. So they really are starting to look at this oversight. That's the one thing about compliance, and you should think about this within your own practice, is that it's hard to backtrack. It's hard to step back. It's hard to go backwards and say, shoulda, woulda, coulda. It's what should you do prior to making sure that everything is accurate, making sure that things are appropriate. Look at the mess they created for the first month of telehealth. So now they're going back and saying, well, this is what we want to see. And everybody's saying, well, that's not what you wanted to see at the beginning. So now we're going to have to go find this information because Medicare realizes how much money has been pushed out, and they've got to pay for some of these programs. And otherwise the agency will bankrupt. The program will just go under, and we can't have that happen. And so just be aware of that you could be seeing some definite differences, some requests for records and so forth, because they're just going to have to find a way to make that work. Okay, so my coding question today, and I actually had an interesting one. I actually like this coding question. It has to do with robotic assisted surgery. So this is the technology that allows the surgeon to operate from a console, remote from the patient and not in sterility. So many hospitals have adopted this technology. Typically, I see it in urology, gynecology, general surgery, colorectal surgery is really big, also hernia surgery. But in 2007, the AMA and the CPT editorial panel came out and said there's really no need for a new CPT code or a unique modifier for surgical procedures performed using robotic assistance. They said physicians are advised to use the CPT code that accurately describes the basic surgical procedure. Also, do not put a 22 modifier on it, because that's not appropriate if the sole use of the modifier is used to report the use of robotic assistance. Now, I have a little bit of a problem with that, only because there's no unique code for the robotic procedures, and the additional time and effort that is spent setting up, docking, and undocking the robot, they're not reimbursed additionally. Now, I know that's more inpatient or hospital work value, but still you're not going to get anything differently. There is a HCPCS code, S as in Sam 2900, and that says surgical techniques requiring the use of robotic surgical system, but that's a hospital. That's what the inpatient hospital facility uses. It's not a reimbursable code, so it's not recognized separately. It's more just a informational code, if you will. But a question came up is, Terry, how do I code for a robotic total laparoscopic hysterectomy uterus? And so only, and not with tubes and ovaries. And so basically, it's 58572, and it is not with any other extra code. And so you just want to make sure that you are coding the actual code. Now, I would want to see the robotic language. So you have to call it not just the laparoscopic surgery, but you also want to have the robotic assistance within the report. And again, when this is something that is completed, especially laparoscopically, make sure you look at coverage policies for laparoscopic surgical procedures, because also the policies for that would apply. And you want to make sure that the payer, it doesn't feel that it is something that's experimental, because everybody now covers it. It's just a different way to do the surgery. So I wanted to make sure that you had that information. Good question, though. I haven't had that in a really long time. So our coding question was brought to you today by Ozark Medical Coding. Join us for the Advanced Cardiology Virtual Summit, September 11th and 12th, all on demand with Q&A opportunities on Zoom both days with me and 3 other speakers. Go to cardiologysummit2020.com/register. If you forget the /register, nothing comes up, just so you know. So again, cardiologysummit2020.com/register. And it actually is booking really well right now. So I think we have 10 CEUs and a lot of good information. The CodeCast podcast is also brought to you today by Charles Schwab. Be a more informed investor. Follow us for news and insights to help you own your tomorrow. AboutSchwab.com. So my personal tidbit this week is about taking some time off and taking a break. So I'm actually going to be going to Arizona for a couple days to move my daughter out to her new life. And so I'm going to be driving out there just to unplug, not just for her, but also for myself. I need a couple days off. I don't get to go to Hawaii APC this year. So because of the pandemic, everything was shut down. We did things virtually. Can't wait for next year. And let's face it, none of us can wait for 2021 to get here. But this is something about taking a break. And I wanted to, if you can't get out of town, have you ever heard about something called, or a phrase called staycation? I used it on a podcast and that I used to do called The Bun Life. I wanted to relaunch it, but it doesn't look like that's going to happen. I had so much fun with that for almost a year, but it doesn't look like the relaunch is going to happen. But one of the episodes I had was really, trying to find a hotel room that's close to your home, unplugging, bring a book. Most of them have the pools open with responsible distancing, of course. And then just put your phone in a drawer for a couple days. Prices are at an all-time low. One of my favorite hotels around where I live, Hilton Garden, is usually around $200 to $300 a night. Right now, it's $49 a night for the same room. And try to find that deal, because it's just, you need a change of scenery if you are still working from home, even if you're working half from home and you've been back to work part-time. But find a deal, find a room with a view, an open pool, room service where now you have to pick up your food. They usually don't have the inside seating, but pick up your food. You can eat it down by the pool. You can eat it in your room. And while the weather's still warm, before your kids are 100% back at their distant learning, or if their school's brick and mortar, make sure everybody's getting a break. Take that mini vacation. Find that, $150 just for a couple of days. Even if you can only do one night, you can do it under $100. So I hope everyone really tries to take a staycation before we get back into it, now that we're heading towards fall, and to recharge, unplug, and get ready for, we're coming into year end and month end. So everyone get your break in, but hopefully everyone takes my advice on that. Don't forget to send a review and a rating on Apple Podcasts if you can. I really appreciate when you do that. We have 100. It's funny. We have 100 ratings, but over 200,000 downloads. It keeps us in business to have more than that. So if you can give us a 5-star rating, we really appreciate that. And so I really, really appreciate that. And we've had some great, great reviews. So for those of you that have done a review for me, thank you so much. You've been very, very sweet, and I really appreciate it. Also, shout out to my new YouTube listeners and some of the reviews you've put on there as well. So that's been just awesome. Okay, everyone, on this Terry Tuesday, thank you for spending some time with me. Make it a great day and a great week, and thank you for listening to the CodeCast podcast.
For more information on medical coding, billing, auditing, and compliance, including how to hire Terry, follow Terry on Twitter @TerryCoder1, or visit her website at www.terryfletcher.net. Podcast producer Joe Kuzma. Music producer Dassassin Music.